Let me reintroduce those folks that are up here. Dr. Webb Ross from Pacific Health Research and Education Institute, Dr. Melvin Yee from Kokini, Dr. Stuart Peng from Kaiser Permanente, Dr. Michiko Bruno from Queens, Professor Amy Lauer from the University of Hawaii. And we've added a couple folks that are a little bit unusual. Mrs. Pat Bemis, who is a female caregiver, and Mr. Mel Hayase, who is a male caregiver for a female patient. Because we've recognized that there's some challenges that are unique to caregivers. The doctors do a lot of the work, but a lot of the day-to-day work is taken care of by our caregivers, so we asked them to join us. Before we started, I want to make two real quick announcements. Dr. Peng reminded me that next year, June 4th to June 7th in Kyoto, Japan, is the next World Parkinson Congress. We'll have several of the doctors going. My wife and I used to live in Japan, so we decided we're going to go do some vacation and probably also attend the World Parkinson Congress. There's a Facebook website, or I can provide you more information if you look at wanting to go. It's a great opportunity. 4 days of just Parkinson, just a tremendous amount of information and great stuff. And our doctors can talk more about that later. The second one is the story that I wanted just to share with you. A couple months ago, I sent out an invitation or solicitation looking for volunteers for a high school student who's doing a study on meditation and facial recognition in Parkinson patients. And his father's actually out in the resource fair, and he grabbed me and says, "Hey, I just don't know if Ben let you know, but Ben received second place in the state for his study, and then he's going on to the International Science Competition." And that is the study that there was 36 volunteers, of which 25 people ended up being included in the study. And that was primarily due to this organization, this group right here, because he said they went to other Parkinson organizations and they wouldn't have anything to do with them. But because we embraced it and folks actually participated, he's done well. And that is, folks, that's the future of our research. There's going to be, he's going to come back, they're working on another study, so you'll probably see more solicitations coming out from me on that. But I just want to give you an update on that, say great job, and thanks for all your participation. Before we begin in the actual panel, need to lay out a couple short guidelines. We're going to kick off the panel by asking a couple of our panel members to make brief remarks related to the Symposium's theme of communications and Parkinson's. I would ask the audience to hold your questions till after all the panel members have completed their remarks and we begin the Q&A portion. We have 2 cordless mics that are going to be out in the audience today. So if you have a question, please raise your hand and a volunteer should bring those around. Got to make sure that's going to happen. When you ask your question, please state your name first and where you're from. Just first name only. You don't need for last name. And remember, please be courteous to panel members and other participants. We've got a record number of participants here today, and a lot of people have questions, and I also have questions that were submitted when people registered. So please be brief on your questions. We're also looking for questions that are of interest to the group, more than just your individual situation. Lastly, if we don't get to your question during the panel session, we'll ask our expert panel to answer those questions in writing afterwards, and we'll forward those answers back. So with that, I would ask Dr. Ross to be our first one to provide some remarks before the panel.
Thank you. Thank you very much for inviting me. I've been doing this for a long time, and these conferences just get better and better. And it's just an honor to be here and see a lot of my friends. And it's been a great conference. Thank you, Jerry. Jerry asked me to say a few words about research, and actually he said that all that needs to be said. That was such a great story about a young investigator who's already doing good work. I have been in the field of neurology. I started over 30 years ago, and when I started out as a neurologist, people came up to me and said, "Why are you going into neurology? I mean, you're great diagnosticians, but you can't do anything for the patients." And over the last 30 years, we've had incredible advances in multiple conditions, neurological conditions like multiple sclerosis and stroke and migraine and seizure, and especially Parkinson's disease. And it's just been a real pleasure for me to work in this field and see the advances that have been made. And all of these advances have come through research and participation in research by people like you all over the world. I mean, you're what make the difference. And it is just spectacular to be able to work with folks that give their time and their just volunteer to participate in research in general and clinical trials in particular. And so I just thought I'd take just a minute to talk a little bit in particular about clinical trials, because it's clinical trials that we really learn about whether an intervention or a treatment, whether it's a drug or a device, has effectiveness. And the gold standard of assessing effectiveness is the randomized, placebo-controlled, double-blind clinical trial. So what do I mean by randomized? By randomized, I mean that we flip a coin and a person is assigned to a particular treatment group. So it's all random. And what do I mean by double-blind? What I mean is that when a person enters into a clinical trial that's looking at some kind of intervention, and after they're randomized to the different interventions that are available, nobody knows. The participant in the trial doesn't know, and the investigator doesn't know which arm that person is in. And then placebo-controlled just means that in among the different treatments, one of the treatments is often an inactive medication that is a placebo. And the reason that this is important is that there is this thing called the placebo effect that is in about 30% of the time, an intervention that really doesn't work shows effectiveness, because our minds are powerful things, and if we think that something's going to work, oftentimes it does. So the only way of getting around that placebo effect is to have a trial that has a placebo arm in it. Now sometimes when we're comparing medications, we don't have a placebo arm, but often when we're looking at new medications to see if they're effective, we have this placebo arm. Now, a lot of you out there are going, oh, he wants to treat me like a guinea pig. And, I hear this all the time. And in fact, there is a pretty sordid history, in the past where investigators really took advantage of people and weren't ethical in their approach to some of these clinical trials. There were trials that, that picked on certain populations that couldn't advocate for themselves, like prisoners or retarded children. There were unethical trials like the clinical trials that went on in Nazi Germany. So several years ago, there was an international group that got together and came up with a code of ethics for clinical trials in general, but human subjects research in general. And that conference came up with 3 tenets. The first one is respect for persons. That means that research is voluntary, and you can invite people into it, but they make the decision about whether or not to participate. The second is beneficence, and that is you try not to do harm. You minimize the risk to the extent possible. And the last one is justice, and by that we mean that everybody bears the advantages and the disadvantages, the risks and the benefits of the research together. There's no single group that's singled out to take on all of the risks. So with those, we have formed these institutional review boards that every center that does research has. And these institutional review boards look at these projects that want to involve human subjects in research. And they look at it from the aspects of those 3 tenets. They look to see if it's safe. They look to see if it's scientifically sound. And they make sure that there's adequate informed consent in the trial. So I think that this has really changed the way that people now think about research and think about clinical trials. There is now a very high bar, a high standard of ethics that goes into this research, and it's helped to get people involved in research. So if you want to participate in a clinical trial, what are some of the questions that you should ask? Well, you should ask, what are the aims of the trial? Who is sponsoring this trial? Is it the National Institutes of Health? Is it a pharmaceutical company? Is it a foundation? Who leads the trial? What are the risks and the potential benefits? Because in clinical trials, there may not be benefit. You may not get any benefit directly from participating in these trials, and you should understand that from the get-go. And there may be significant risks. How long will you have to be in the trial? What are some of the procedures that you have to go through? Are you going to be paid for participating? Will you be reimbursed for your transportation? You should never have to pay to participate in a clinical trial. So that is up front. If somebody comes to you and says, I want you to be in this study and you just have to pay this amount, please turn the other direction and run. And it sounds funny, but it happens all the time. You do not pay for participating in research, right? This is voluntary, and it shouldn't cost you anything. So these are just some of the things that you should be thinking about when you participate in research. And like I said, clinical trials have resulted in just a ton of advances. And right now, there are over 400 clinical trials, intervention trials for Parkinson's disease. And they run the gamut. They're trials that are looking at treatment of the motor symptoms of Parkinson's. They're looking at trials that are treating the non-motor symptoms, such as excessive daytime sleepiness, depression, dementia, constipation. There are trials that are surgical trials that are looking at new surgical treatments of Parkinson's. There are medication trials that are looking at novel or new medications that may get rid of some of the bad proteins that build up in Parkinson's disease. And then there are very interesting trials that are using medications that are already approved for another condition that seem to show promise for people with Parkinson's disease. So I think we're on the verge of great discoveries. Whether or not are we close to a cure, I can't say that we're close to a cure right now. I'd say, and I say this unfortunately every year that I'm here, I think we're at least 10 years from an intervention that will slow down the progression of Parkinson's disease or stop it or prevent it, right? So, but I think it's going to be there, and I think there's going to come a day where this conference won't be necessary because there won't be Parkinson's disease. But I just want to thank you all. I see a lot of people in the audience who I know from participating in research, and I want to thank you, and thank you for your patience, and I'll stop now.
Thank you, Dr. Ross. Dr. Yee, I'll kick it to you for your comments, sir. Yes, sir.
Well, thank you very much for having me come here. I was asked to sort of talk about how do you communicate with your physician about your medications and your symptoms, because that's a very important thing. And the first thing you got to realize is that, when you come to see your doctor, it's just a very small snapshot of time. And the patient's wife or our caregiver will say, oh, he does so good in your office, but when he's home, he doesn't do that. And I threatened that, well, I'll print up a big picture of myself and sell it so that when I'm not doing well, you can just show this picture. And the Dr. Yee said, well, I'll do better. But really, what tells us what's going on is what you tell us. Okay? So there are a few things to remember. And the first thing is, if you can't remember, write these things down. Right? Because a lot of times they say, well, I was going to tell you these things, but I can't remember. I'm going, well, okay, you've got to write it down. All right? The other thing to remember is that, we're all pressed for time. So make sure that you have at least one or two things, important issues, that you get to discuss. Right? And specifically, you know, what we are really looking at in terms of medication and treatment, we want to see, well, is the symptom that we're trying to help getting better with the treatment? And are there side effects? Right? So the first thing you have to do is focus on, well, okay, I want to tell the doctor that I'm not doing so good, or I'm doing well. But you know, if you just say, well, I'm not doing so good, that doesn't help me very much. You got to sort of tell me what is not doing so well. So I like to get some objective things, like, well, I can't get out of the chair, or it takes me 5 times to get out of the chair. I can't walk quickly. I can't turn around. Or worse, I'm falling. I can't dress myself, or I can dress myself, but I can't do the buttons. I can't cut my food. I can't use chopsticks, or I can't use a knife and fork. It's taking me longer to do things. So you have to have some measures by which you judge how your Parkinson's is doing. And those are the measures that we should judge, well, is the medication or the intervention that we did it help or not, right? You got to be able to tell us that. Others, we don't know. Similarly, you have to figure out, well, is there a side effect for the medication? So the first thing I'll tell people is, if something changes for the worse after they change your medicine or start your new medication, the first thing to blame is the medicine. Okay? Now, there are some things that are very, very common. So, for example, dizziness, right? Dizziness is a very common complaint, right? It's a very common side effect. But also, a lot of people complain about dizziness even before they get the medication. So you have to distinguish what was there before and what changed after the medication. Sleepiness, right? Is the medication making you sleepy? Right? Very common problem, right? And more common with certain medications, such as the dopamine agonists, like ropinirole, pramipexole, or the Nupro patch. Is the medication making you more confused? Right? No, Parkinson's disease in and of itself can make you confused. But, gee, I just upped the dose of my Cinnamate, and all of a sudden, I just can't think straight. Well, that's an important thing for us to know. Are you having hallucinations or funny thoughts or getting sort of obsessive-compulsive behavior, right? Because if that's a direct result of the medication, that's something we clearly need to do something about and cut back. So what we're trying to aim at, you have to think about what symptom we're trying to improve, and did it get better with the medicine, or was there a side effect from that? The other thing you should think about is the timing of these things. Like, so are some of the symptoms related to when you took the medication, right? Are you getting on or off? And it's important, sometimes, every so often I talk to my patients, and I think they're saying that they're off, but actually they're saying that it's their Parkinson's is getting worse. So you have to be able to distinguish things like a tremor, right, which is your Parkinson's disease, from a dyskinesia, which is a sign of dopa excess. And I think it's important for us to know how you're doing, otherwise we can't judge how things are going. We can't make recommendations as to what to do with medications or therapy. So you got to tell us.
Thank you, Dr. Yee. Dr. Bruno,
Okay.
would you care to offer a few comments?
Hi, thank you so much for having me, and it's such a great, it's great to see everybody here. It's a successful symposium with so many participants, and HPA being such a wonderful organization with lots of volunteers. So anyway, I'm going to try to be brief here. I was asked to talk about quality of life communication between caregivers, patients, and doctors. So I really echo what Dr. Melvin E. just mentioned about the symptoms and medication and how to manage that. but I think it's a good extension of that to add the quality of life aspect. So I echo Dr. E about writing your notes, because if you just came and said, I feel bad, that's, of course, it's frustrating to have Parkinson's, but if it's just bad, it's not as, I guess it's a little bit difficult to assess that, as opposed to being more concrete about things. And also, as frustrating as it is to have Parkinson's, it is what it is, and we want to make the best out of it, and life continues, and we want you to have the best quality of life that's achievable, and we want to do that together as a team with physicians, caregivers, and other providers. So and communities and other, other patients. And so anyway, so the quality of life is, I guess it's kind of weird to say quality of life is important, but it just extending to the symptom that Dr. E talked about, we want you to be concrete. So sometimes you might have to have small achievable goals. For example, rather than just saying, I hate having Parkinson's disease, we want to say, well, I do have Parkinson's, but I want to maybe attend my granddaughter's graduation. How could we achieve that? And find some value, find some appreciation in what we still can do and have, and try to work with your providers and trying to address concrete hurdles if there is. How do you get to the airport? What do you do with your medication? So being concrete, having goals, and we actually, as Dr. E said, we don't know your life as well as you do, so we need you to actually reflect upon what is important to you and prioritize that, because sometimes we have to let small things go. Sometimes, as example that Dr. E gave, the medication may help tremor but may cause side effect, but sometimes maybe controlling tremor is important than the side effect, or sometimes the side effect is worse than the controlling the tremor. So we need you to give your value about your life, and discuss that, incorporating that into discussion of medication and treatment choices. So.
All right, thank you, Dr. Bruno. Now, just one last call. Any of the panel members like to offer up any final opening remarks before we go to Q&A? Anybody? Okay. Well, we're going to... No?
No, I'm good.
No, he's got the mic because he's got a question coming up. So what we're going to do is we're going to go to the Q&A session. Melanie and Amber at the back, they both have the mics for anybody in the audience that wants to ask a question. I'd ask you to raise your hand and they will come to you to ask that question. And any questions? If not, I'll start out with one for Dr. Peng. This is out of the question bank that was submitted prior to the symposium. And it really, one of the courses of treatments that we have, everybody knows, is deep brain stimulation. And so a couple different folks were asking questions on DBS. One of them was asking, how do they know if it's an optimal solution for them, and what is the success rate upon implanting the DBS?
Okay, that's a very good question. So deep brain stimulation, as you all know, is an option for patients who have progressive Parkinson's disease. What you usually do is you sit with your physician and you decide, are your medicines as effective as you want them to be? If you're having significant side effects from the medicine, or if the medicines are wearing out before and is not as effective as previously, or if you have significant abnormal involuntary movements, then it's time to discuss deep brain stimulation. The procedure is done after you have an evaluation by a neuropsychologist to make sure you don't have any significant cognitive impairment or significant depression, because both of those things can get worse after the surgery. You also have an MRI of the brain that's done to assess what the brain structures look like. You are then referred to a neurosurgeon that will appraise you on the risks and benefits of the surgery. And at the same time, you'll meet with one of the reps from the two companies that do brain stimulation. Now, it's not a procedure for everyone because there are complications that can occur, and the success rate is not perfect for everyone. The majority of patients that I have referred for deep brain stimulation have done very well. I actually have 2 patients who no longer take medications because the deep brain stimulation has helped them, but that's not what you'll see with everyone. Each patient is different. The procedure takes about 4 hours. It's a 2-part procedure. The first part of the procedure is a hole is made in the brain and you're asleep, and then a wire is placed inside. You are then woken up, and they monitor your symptoms on the opposite side of the body just to make sure that the probe is put in the correct location. After it's correctly in the correct place, then the wire is tunneled under the skin and left in the chest. It's done on the opposite side also. You come back about 10 days, so that procedure takes about 4 hours. You come back about 2 weeks later to have the battery pack placed in your chest. Usually the wires are connected and it goes to one side of the chest. Okay, so that's a 2-part procedure. The second procedure is probably a 2-hour, and both times, the first time you stay overnight and go home the next day. The second time you go home after the surgery. Okay. You then come back to see your physician about a month later to start programming. The programming takes several hours the first time you go in, and then subsequently you come back about every 2 to 4 weeks to program the stimulator up or down to control the tremor, the slowness, the stiffness. While you're on programming, you also continue to take your medications. Okay.
All right. Thank you, Dr. Peng. I understand we have a question over here. Okay.
Yes, my name is Bob. This is a great opportunity for abundance of information I've seen in my many years. My question is drooling. Is there a procedure that can be done to slow down the drooling, or is it something we just got to live with? Thank you.
In terms of a procedure, I am not aware of any procedure to help. I know there are some medications, and maybe one of the other doctors can kind of speak to that. I just know I have had some clients that have had medication or patches to help with that. I think the root of a lot of the excessive drooling comes from reduced initiation of the swallow. So you're not swallowing as regularly, and there's some sensory changes, so you don't feel as it may pool the same way. So unfortunately, I think that would be, in some respects, an ongoing symptom, but I don't know if there's anyone else that can speak in terms of medication options.
In general, I am not in favor of medications for drooling because they tend to make people sort of sleepy. I tell my patients to suck on a piece of candy, right? I have actually, in very advanced cases, patients who, for example, have a feeding tube but have a lot of saliva and they're drooling a lot and they're choking on the saliva and things. I've done some Botox injections in the salivary glands. That'll decrease it. But the downside of that is that in someone who's otherwise up and moving around, if you produce less saliva, it's bad for your teeth. Yeah. It's poor on your dentition.
All right.
Other comments?
There is another option that some physicians might try, and that's called atropine. Atropine is it's usually used for the eyes, but you can put a small drop, not a dropperful, a drop on your tongue, and for some people that does help. The problem is that atropine does have side effects, so that's something you would have to discuss with your doctor. But the drooling that you have, unfortunately, is very common in Parkinson's disease.
And Dr. Borman out in the audience has a comment too.
If I may add, there is one medicine that's related to atropine that does not cross the blood-brain barrier called glycopyrrolate. And I've had quite a bit of success using that, which reduces salivation but doesn't get into the brain for some of those side effects.
Great, thank you very much. For the next question, we're going to go to the back corner over there. Oh, two.
My name is Fred, and I wonder if you could speak to Parkinson's fatigue.
Nobody wants to talk because it's a very frustrating condition. I'll just say fatigue is maybe the most common debilitating symptom of Parkinson's disease that I encounter, and actually, it's very well described in the literature. There are actually clinical trials now that are looking at new medications that might help fatigue, but so far the trials that have looked at treatment of fatigue with existing medications have been disappointing. So I really rely on other methods, and I'd be interested to hear what the other panelists say here. But I usually tell people to take frequent naps. There's nothing wrong with that. They can be refreshing. To exercise, because oftentimes exercise can alleviate fatigue at some level. And those really are the interventions that I kind of rely on. As much exercise and then naps when they feel like it.
Hey, Dr. Ross, before you get off, what about the over-the-counter stimulants that we typically use called nicotine and caffeine?
So actually, I had a question about caffeine, and there have been a couple of small trials of caffeine and excessive daytime sleepiness that have seemed to show some benefit. Interestingly, when there was just a study that was released that showed that people with Parkinson's disease, when they took caffeine, and the levels of caffeine in their blood were compared to individuals without Parkinson's disease, the levels in those with Parkinson's disease were much lower, suggesting that they weren't absorbing the caffeine as well as people without Parkinson's disease. And you all are probably familiar with a lot of information that's coming out now about the gut microbiome. That is all the bacteria in our intestines that help us digest food and keep bad things out and good things in. Well, there's some evidence of a difference in the gut microbiome in people with Parkinson's disease that may inhibit absorption of some kinds of medications, and it may actually inhibit absorption of caffeine. So, but yes, caffeine has been shown to be somewhat helpful for fatigue.
Yes, Parkinson fatigue is one of the most frustrating symptoms, I think, for people, but we also want to make sure there is no underlying other medical problem that is correctable, such as anemia or vitamin B12 deficiency or sleep issues. So I think sleep issue is big. We want to make sure you don't have other sleep disorders such as sleep apnea. I guess Parkinson can cause restless leg syndrome and REM sleep behavior disorder, so evaluation of those may be necessary. Exercise is super important, not only just helping the fatigue at the moment, but preventing it from getting worse. And again, constipation may contribute. So also eating big meal at a time may make you tired, so eating smaller meals at small intervals might be helpful. Drinking lots of water and evaluating medication, because sometimes people are taking a lot of medication. Some of them may not be necessary, so treating to your internist about if all of the medication is necessary. So, but the fatigue that comes from the disease itself is very difficult.
Thank you. I think everybody's been participating except for my two caregivers, so I'm going to pick on them next. And Pat looks at me real happily. No, the reason we ask the caregivers to be on the board because they bring, like I said, another perspective. And so my question to both our caregivers is, what is your biggest challenge as a caregiver, and how do you overcome the motivation issues that many Parkinson patients, including myself, typically have, that we get on the sofa and it's watching TV and it's just so much easier just to stay locked down. So how do you, as a caregiver, how do you deal with that? Not an easy question, huh, Pat?
I think for a very long time, I confused my husband's facial expression, which was very apathetic looking, very disinterested, as that he unplugged on purpose. He unplugged from our family, he unplugged from things that he used to really enjoy just by looking at his face. But it took me some time to realize that if I asked him, would you like to go take a walk? His face changed and said, sure. And so it was a really long time. I thought, well, he's depressed. He doesn't really want to socialize. He's feeling embarrassed about his symptoms. I made up a lot of things before I started to connect with him and not assume that if he wanted to do it, he would. And asking him, I'm going to go out and walk over to the supermarket. Want to come with me? Sure. Now, if I was getting ready to go to the supermarket, he would never volunteer and say, oh, I'll go with you. It wouldn't occur to him. So really trying to gauge, I think it's been a learning curve for me to try to gauge, not by facial cues, but by just talking more about it. Asking him, would you like to go out for lunch? Or would you like to stay in for lunch? Not just assuming that since he's not going to get lunch for himself in the refrigerator, he doesn't want to eat. And I think as caregivers, sometimes we get so caught up in, this is how I behave, and thinking that you used to behave like that. And I don't know why you don't behave like that anymore. So I withdraw. I don't say anything to you because you're not saying anything to me. And it, you know, I'm a very stubborn person. So I thought, well, if you're not going to talk to me, I'm not going to talk to you. And so we played that trip in the car for miles and hours of driving, and I thought, well, I'm just not going to talk and see how long it'll take him before he says something. And then I couldn't hold it in anymore, and I'm like, look, cows. There's cows over there. And he said, yeah, I know, I've been looking. Well, how would I know you were looking? Because you didn't say anything. He says, but they're cows. There's nothing to talk about with cows. And so, you know, here all this time, I thought, he's pissed off. He doesn't want to go on this journey. He's not comfortable. His neck hurts. I made up a lot of information based on non-communication. And it's just really a process. For those of us who are caregivers, we don't have the magic map of what's going to happen next. We don't have a recipe card that says, these are all the ingredients in Parkinson's, and here's the first step. You know, preheat the oven. We come at Parkinson's maybe late because it's not our disease. We expect them to find out everything about it. And then we come in at some point wondering, when did all this stuff happen? You have these symptoms, these symptoms, these symptoms? I didn't know. So hang in there. Give yourself some space and a pat on the back that you showed up today, that you're interested in getting information, and that you're getting support for yourself. It's so important. And before I go, I have a plug. Some of the support group folks have seen this, but my granddaughters, who are 6 and 7, found this book in the public library. It's called A Day with Parkinson's, and what I love about it is it's a beach scene where this little boy realizes his grandpa is doing things a little bit differently now. and how Grandpa and Grandma talked to him about Grandpa having Parkinson's disease. It is so beautifully done. It's in simple language, and my grandkids saw it as a face-out book in the library, and they looked and they said, "It's Park, is that what Pop has?" And they brought it home, and they wouldn't let me read it until they looked at it to see if it was good. And so I highly recommend this, and it has explanation in the back of it about what Parkinson's is for maybe the mom and dad who really don't know. I don't know that my kids know anything about Parkinson's other than my husband shakes. It just doesn't touch them as much as it does, you know, the people that live with him. And so grandkids, if you have grandkids, they watch everything. And they're curious. So you can get this at the public library, and I'll be around if you want to take a look at it. But I had to plug this because it's so cool, and you don't have to buy it.
Thanks, Pat. Now over to Mel.
Yeah, I have some maybe general comments. I've gone through with my wife DBS, and so if any of you have any questions later on, you can come and see me. I can talk to you about that experience. Also, we went through LSVT partially, so if any of you want to ask me questions about that, I can tell you. Some other general comments. I think what made me survive some specific thing that I've lived by with my wife. And my wife, by the way, had DBS exactly 4 years ago, today or tomorrow, anyway. So I've been with her with DBS since then. She's had Parkinson's for about 15 to 20 years. I can't remember which. Anyway. One of the recommendations I have is what I live by is I treat everything I do for my wife, Eileen, as tasks. Simply tasks. Tasks that I do for myself, and I've done it for myself for most of my life, that I just have to extend it and do it for my wife. And so tasks are tasks, right? They're neutral. They're not good, they're not bad, they're not something you want to do and something you don't want to do. That's just things you got to do. And so that's what I do. It's my attitude before I do the task that determines how the task will end up being. And so that's what you have to be careful about. Now, I was asked to be up here as a male caregiver, so I kind of want to shift to that. And I think what I want to add to that mainly is to say that my caregiving of my wife, Eileen, I've become more aware of my maleness. And when I say maleness, I don't mean necessarily the positive side of maleness. I mean the sort of the negative side of maleness. And I have to be aware of that. And you have to remember that my feedback has nothing to do with any kind of random studies or anything like that. It just has to do with my own life experience as a caregiver. And the maleness that I'm aware of, I always have to be aware of, are a couple things, some of which, by the way, I don't know if it's a fact or fiction or my own imagination. But one of them has to do with being more aggressive, being more prone to be violent, and being aware of that. And I tell my wife that I mean to her. Sometimes I feel like she would be better off in a care home or some other caregiver to care for her rather than me. Because I'm her husband, and as a male, I'm very much aware of some of my impatience and tendency to be loud with her, tend to want to react faster, tending to be more aggressive with her. Some things, or most things, of which a caregiver, objective caregiver wouldn't do. But I, as a husband, would do, or maybe as a male I would do, because that's who I am. And so I'm aware of that very often. We went through LSVT, and one of the things with have you heard earlier, is that you have to be loud. Well, I'm naturally loud, okay? And my wife isn't. So I had difficulty dealing with her on LSVT because I was loud and she was very soft and I could hardly hear her. So anyway, so that was an issue. Eileen tends to be, and again, maybe this is a cultural thing, I don't know. Women tend to be more prim and proper, right? Is that, I don't know, is that learned? Is that learned? I think half of it is learned, but I think half of it is genetic. I think women are born that way, right? You're the empathetic person. You're the one that nurture and give and compassion, and male tend to be the whatever we are. Anyway, and so her being prim and proper, and I'm just the opposite. And so that's what I have to be careful about, because in caring for her, I have to be more aware, and I'm often not, that she wants more privacy. And I don't care, you know. Us men, well, we grow up. In fact, just last week, we were on a trip to Hana. Have you been to Hana, Maui? Hana, Maui, I was born there. Anyway, we were on the way to Hana. We stopped at this wayside restroom, okay? And can you imagine the restroom here on the way to Hana, you know? So I went to the restroom to do my thing. And I went in, and all of a sudden I heard this kid yelling at me, "Shut the door, close the door, close the doors." So what is he yelling at for? Well, he was so upset at me because I didn't close the door when I went to do my thing. Well, anyway, so that's me. I'm not as prim and proper as my wife would be. So I'm always aware of that, the maleness in me in caring for her, that I have to be more aware of, or, well, I can't tell her to be more aware of my maleness and accommodate herself. I have to be the one to accommodate that. But anyway, that's what I wanted to add.
No, thanks, Mel. Thanks for your candor. Very valuable. So I know we had a question back over there. You asking Kevin, or? Go ahead.
First of all, thank you, panel. We have a great support from the neurology community and other providers, and so thank you so much for giving your time, and the caregivers too. That's wonderful insight. My question is for for Dr. Lauer. You mentioned that UH speech department, you have services that you provide. So could you expand on that? And then also let us know, how do we access them? Does it require a doctor's referral? Can support group leaders make recommendations? If you could just talk about that, that'd be great.
Thank you. Thank you for the question. Yes, so we have a clinic. Our clinic is actually located in the 677 Old Gold Bond building on Ala Moana. So we're right in front of the School of Medicine, not on the UH campus, which is where it used to be, but we have a nice facility now in that location. In terms of kind of pipeline and access, caregiver support groups are welcome to make recommendations, but it does require a physician referral to get started. So that's where really the first conversation would be. You can put it on your list of things to talk about with your doctor in terms of getting a referral, and you could request to say that you're interested in speech or voice therapy at the UH Speech and Hearing Clinic, and that would get the process started. I recommend at the same time, for us to do the LSVT program, we do want you to be evaluated by an ENT first. So it would be the process of, so I guess going into the doctor looking for both an ENT and a speech referral, of having that camera that goes through the nose and visualizes the vocal cords. Parkinson's is not the only thing that causes hoarseness, and we don't want to start a therapy without ruling out if there's any complications. You could have laryngeal cancer that could be causing it. We don't want to miss something in the process. So that's just kind of a clearance of seeing an otolaryngologist and the ENT. You would then come in for an evaluation in the clinic where we would do some of those ahs and the highs and the lows and get to know you and what you are experiencing and what your goals are at that point. And we would then submit that into insurance to get authorization in terms of coverage, or check with your insurance company. And we have documentation and support. The LSVT program is excellent in what they provide us as therapists in terms of research to support the efficacy of the treatment. So in general, like Medicare and insurance companies are responsive to covering those kind of treatments. So yes, so getting started would just be talking with your doctor to get the referral process. And if you have any questions, I have cards too that if you need to follow up on anything, but again, it's a UH Speech and Hearing Clinic. Thank you.
Thank you. I'm going to reach back into the bag of questions from before, and we're going to talk about a little bit about exercise, because everybody understands exercise is so key. So there's, as a Parkinson community, we have all sorts of different exercises, and Lindsay Sutton for us is trying to work through a bunch of different types of exercises. So the question is who wants it? Dr. Yee?
Oh.
Nope.
Okay. What's the question?
The question is, how do you determine what is the best exercise regime for the patient?
Well, I think that I must say, even when I first diagnosed a patient with Parkinson's disease, even before I talk about medications, and sometimes even if I don't give them any medication, I stress the need for regular exercise. And oftentimes I will ask them to see a physical therapist first to sort of get them going. My general view is that the more exercise, the better, and the more varied the exercise is better. I think that sometimes if there's balance issues, I would, be more, I suggest things like Tai Chi or yoga. If they have very small steps, I talk about the big movement. I think that people have they have to find something that they enjoy. I think men might be more prone to enjoy the boxing and Parkinson's disease kind of program. But I think it's just important to start exercising, and in the very least, just start walking.
As a follow-up, I'll go to Dr. Peng with the next question. There was a question out of the audience that somebody's looking for fall prevention tips, especially when you're exercising, because the unsteadiness while you're exercising can be a challenge.
Okay, so that's a very good question, because falls, unfortunately, happen as the disease progresses. And what happens with Parkinson's disease, you lose your center of gravity. So all of us, when we walk, we usually walk straight. With Parkinson's, your center of gravity is pitched forward. That's why they tend to fall forward or they fall backwards. So one of the ways to avoid falls is to get into a physical therapy program or to start an exercise program. As you all know, the Parkinson's Disease Association worked with the Y, and the Y has exercise classes that are, I think, at most of the Ys. And if you go to those classes twice a week, sometimes they help you in terms of learning how to get up so that you don't fall backwards, how to turn so that you don't fall when you move side to side, okay? That's very important. And then when you do work with a physical therapist, they'll give you tips on whether you need to use a cane or if it's better for you to use a walker, okay? We don't like to see patients fall because that increases the risk for having fractures. Unfortunately, the medications do not prevent falls, as well as the deep brain stimulation. It really doesn't prevent falls. So you have to work on that. One of the other things I think is there is what's called PD boxing. I think you've heard of that. I don't think we have a pure program for that here in Hawaii yet, but they are working on that with the Y, where you know that boxers have to stand a certain way and have to learn how to balance. And they have Parkinson's disease programs on the mainland with boxing that helps with balance and helps with coordination. So I think that the Hawaii Parkinson's Association is working with the Y on that.
I thought that, Kevin, can you comment? Aren't there some people who are trained already for boxing and PD?
It's in pockets. It's something that has been on the radar. I think we're going to discuss today at the lunch to try to do something that's more island-wide for the barking. So right now we don't have a island-wide program. There are a few organizations that are doing it in pockets. I think OrthoSport, who's out here, has a program. Kalakaua Gym has a gentleman who's training some people. So But the goal is to make it island-wide, like we did with the exercise classes at the Parkinson's. There are 8 branches, so geography is covered throughout the island. So that is definitely one goal. One comment on balance. Big part of it is boxing helps. Tai Chi is fantastic for balance. As Parkinson's progress, your internal meter's not working anymore, and so you really have to kind of learn to self-manage your center of gravity. And so it is good. Those classes are great, but Tai Chi, yoga, and being referred to a physical therapist with some techniques, just because, again, medication and DBS won't help that. So anyway, thank you. A big plug for the YMCAs. There is a listing on the website. There's a listing on the little placards out there. The classes are twice a week, and there will be a new training June 14th. So if anybody who's interested in doing any type of volunteer program for physical fitness, physical activity, have them contact HPA and invite them to that training. So we're trying to perpetuate and we're trying to grow different programs for physical activity. So thank you.
Thanks, Kevin. Gentleman along the wall has been very patiently waiting for me to recognize him. Please.
Thank you. I believe Dr. Ross was talking about gut bacteria and how individuals with Parkinson's have a dysbiosis in their gut bacteria. Can you talk about chronic inflammation and leaky gut syndrome and how that can affect people's neurological health and cognition, and things that can be done, such as ingestion of bone broths and polyphenols and like curcumin, for instance? Thanks.
So I don't know a whole lot about this area. I do know that people with certain types of inflammatory bowel disorders have a higher risk of developing Parkinson's disease. And you mentioned curcumin. It's one of the mechanisms of cell loss in Parkinson's disease, we think, is through oxidative stress. That is, in the normal metabolism of cells, of course, waste is created, and we have mechanisms in our body that rid the body of those wastes. And there are periods of time when something overwhelms that system, or the body doesn't have the natural antioxidants that get rid of those wastes. And so a lot of the therapies that we're looking at now are very potent antioxidants, and curcumin is one of those. Cinnamon also is in that same category, so that may be helpful in slowing the progression of Parkinson's disease. We don't know that yet for sure, but it's certainly being considered. So somebody else may.
Thanks, Dr. Ross.
I'd like to just add one more thing about the exercise. I was at a meeting last week where this topic came up, and I thought it was a fascinating talk. It was by an investigator who does mouse research, and she was able to show with some of the mouse models of Parkinson's disease, when they did aerobic exercise, that it actually increased cell processes and cell connections. But the type of exercise that was the most effective for increasing those connections was skill-based types of exercise. It seemed like exercise that required a cognitive contribution to that aerobic exercise were the most successful in increasing those connections. So things like boxing, where they're skill-based. Other exercise like tango dancing and drumming. We're starting a project at the VA now of African drumming to see if that might improve quality of life or improve motor symptoms of Parkinson's disease. So I think you might be seeing more of this, and it may not be that all types of exercise we know are helpful, but it may be in the future that it's going to be these more skill type related exercises that are going to be the most beneficial. So.
Thanks, Dr. Ross. Before I go on to the next question, hang on just a second. For those who don't understand and aren't keeping up with the reading, when we're talking about the gut bacteria, the current thinking by the researchers, and this was the update that we were given at the National Parkinson Policy Forum last month, was something is happening to mutate the bacteria in your gut, which in turn is mutating some of the genes in your spine that produce some of the proteins that is carried up to the brain that are killing the dopamine producing cells. But there's also a school of thought saying it's either nose because you breathe in so much or the gut because you take in so much into your stomach. So that's kind of the current thinking, kind of in layman's term. Hopefully the doctors won't smack me around for getting it wrong, but I just wanted to explain that for those who aren't keeping up on all the research. Now into the back corner over there. I'll come back to you, sir. And I'll go ahead and field that question myself. The answer is not yet, but I'm working on it. And what happened, just by chance, I happened probably 18 months ago, 2 years ago, something like that. I ran into the president of the Hawaii Interior Design group. Well, I forget what exactly their name is. And we're starting to try to work with them to provide the information to the home building community to help them understand what we need as a Parkinson community. I said, I've started that. I haven't got there yet. But it is a great idea because once we go through the home designers, we also reach out to the general contractors. And that's kind of the way I see it. I just don't have enough people. It goes back to volunteers. Volunteers. I need more volunteers. Kevin?
Just one comment on home assessments. Your physician can write a prescription to an occupational therapist or physical therapist, and typically home health agencies might be the best ones to come into the home. Some other agencies might. Also, there are some non-for-profits that are doing fall prevention. Project Dana, it's spelled Dana, but it's called Project Dana. They actually will come into the home and do a home assessment, and actually, depending upon what funds they have at the time, we'll even put up grab bars at their expense and those types of things and make some great recommendations. And they actually have a team that's trained really well to go in. So you could probably look them up online, and then, yeah, so thank you.
On the Big Island, we have a program with the fire department. They're paramedics and EMT personnel, and they are coming and doing home assessments. And we've had several people in our support group in Hilo have them, and it was excellent. So I don't know if that's here on Oahu, but it's worth looking into. And they may copy that program here. We
can take a look and put out whatever information we find. But I know on Big Island you have several things that are much better than we do here on Oahu. Unfortunately, no, I'm serious. You know this from the conversations that we've had. Let me go to the gentleman in the very center, please.
What is referred to as brain fog has been a major problem, and I wonder if any of you have some suggestions as to how this might be alleviated.
No. So, I mean, brain fog is a little bit like fatigue. It's a symptom that is kind of nonspecific. Lots of people, such as myself, have brain fog frequently. So, and I think the first thing to say is to go back to what Dr. Bruno said a little while ago about fatigue. You need to be sure that you've ruled out all the other things that can cause clouding of consciousness or brain fog, and that can be medications, that can be other physical conditions. If you do formal neuropsychological testing on people with Parkinson's disease, almost 100% will have some degree of impairment in some neuropsychological domain, and oftentimes it's the domain that is involved with the executive of the brain. And by the executive of the brain, I mean it's the part of the brain that's involved in planning information, in putting things in the right order, in multitasking. And a lot of my patients say, you know, when they come to me, you know, I just can't multitask like I used to, and I can't follow through on tasks. And so while that's a real common symptom, it's sometimes really difficult to break it down, because it could be related to impaired executive function. It could be related to apathy, just plain apathy, which is also very common in Parkinson's disease. It could be related to major depression. And again, it could be related to medications or some other kind of condition. If you've gone through the list and it's just fogginess related to Parkinson's disease, then you know, there are medications that we use for conditions like Alzheimer's disease that have been shown to be somewhat beneficial for people with Parkinson's disease to help their cognition. And you know, I would urge you to talk to your neurologist or your primary care provider about this. But these are medications like donepezil and rivastigmine that can sometimes help with memory. But beyond that, we don't have a lot of good interventions. You've probably heard people say that one way to avoid losing your memory is to use it. And in my way of thinking, there's really not a lot of good evidence to support that. I mean, you know, we say do crossword puzzles and, you know, go online and do memory enhancing programs. And there's really not a lot of good, solid evidence in my mind to support this. And part of the reason I say this is that, you know, conditions like Parkinson's disease and Alzheimer's disease really begin probably years before they are diagnosed. They're very slow in progressing. And so a lot of these symptoms can crop up before the motor features of Parkinson's disease. People can be depressed, they can be apathetic, before they get a lot of the motor features of Parkinson's disease that allow the diagnosis. So actually, the fact that, that people aren't able to do puzzles may not be, they just may not be able to do it early on. It's not that they may not have they may be apathetic, they may have the cognitive impairment before actually they develop Parkinson's disease. So it's hard to know what came first, the cart or the horse. Maybe somebody else has something to add to that, I don't.
All right.
I really just can ditto what Dr. Ross says. I think that you should be sure that it's not side effects of the medications, for example. I think that if you're having difficulty sleeping and taking some of the over-the-counter medications that contain diphenhydramine or Benadryl, that could sort of make you fuzzy the next day. And then, of course, a lot of the medications in and of themselves can make patients feel sort of sleepy and not quite as alert. But unfortunately, a lot of it is just part of the Parkinson's disease.
All right, thank you, doctors. My little birdie on my clock is telling me it's time. We're about out of time, but I got time for one more question from Brother Teloy.
Hey, Doc, thank you for coming and helping us out with our questions. My question is two-part. Number one is a lot of success, a variety of successes have been dealt with stem cell research. Does the stem cell research have a role in Parkinson's treatment in the future? And what the second part is, are there any new treatments coming out for Parkinson's disease?
So stem cell research involves taking cells that have a potential to develop into many different kinds of cells and kind of forcing them to turn into cells that might help people with Parkinson's disease. So one type of cell would be a cell that produces dopamine. Another type of cell might be a cell that might encourage or produce medications that encourage growth of nerves. And there's been a lot of animal studies that have been really encouraging with stem cell therapy. There are several different kinds of stem cells, and actually there are certain kinds of stem cell therapies that are already being done in Parkinson's disease, in my mind, that aren't ready to be used in Parkinson's disease. And they charge for these treatments, and they have not, in my mind, been shown to be of any benefit. So right now, as far as I'm concerned, there's no existing type of stem cell therapy that has been shown to be effective in Parkinson's disease. Now, there are a couple of trials that are just being started right now. One is with embryonic stem cells, and another one is the pluripotent stem cells that come from skin cells in the skin. And these are being done by reputable groups, and I'm really optimistic that they will be carried out professionally, and I'm very hopeful that they'll show positive results. But that, unfortunately, won't, it may not equal a cure, and for that reason, you know, wouldn't be my choice, I guess, to really put the research funding into. And the reason I say that is the person still has Parkinson's disease. So if, for example, there have been nice studies that have shown when you do brain transplants of dopaminergic cells that the Parkinson's, the Lewy bodies can get into these transplanted cells, so that the disease is still there. The other thing is that it's difficult to control these cells once they get in there. And so you can get side effects from these implanted cells that you might not be able to control. And in fact, there's even the theoretical risk of inducing certain kinds of cancers with stem cell therapy. So while I think there's a lot of promise, we're not there yet. I think there are other kinds of cell-based therapies, gene therapies that are promising. I think that there are therapies that are looking at immunization against the protein that's present that's in the brains of people with Parkinson's disease called alpha-synuclein. And I think that there are medications that are designed to prevent the spread of alpha-synuclein that are in trials right now that are really exciting in my mind. And then there are a lot of clinical trials of medications that are already on the market that are being repurposed for Parkinson's disease. And you know, we have participated in a couple of these trials. Isradipine is a calcium channel blocker that's a blood pressure medication. It turns out that some of the pacemakers and cells that produce dopamine use a lot of calcium, and calcium can be toxic to the cell. So if you block that calcium and switch those pacemakers to sodium, it may be beneficial for those cells. So that trial is just about to end, and we'll hopefully have some good news. I talked to you a little bit about antioxidants. There is very good evidence that high uric acid is actually protective against developing Parkinson's disease, and uric acid is, of course, the chemical that causes gout. But it seems that people with very low uric acid have a much higher risk of developing Parkinson's disease, and in fact, low uric acid seems to be associated with a more rapid progression of Parkinson's disease. So there's a medicine called inosine, which actually boosts the level of uric acid, and there is a trial ongoing right now that's using that medication to increase uric acid in the body to see if it will slow down the progression of Parkinson's disease. I'll shut up in just a minute, but somebody did ask a specific question about diabetes medications, and I think that this is a very interesting topic because there's pretty good evidence that there is maybe a higher risk of Parkinson's disease in people that have glucose intolerance or have a tendency to develop diabetes or have insulin resistance. That is, the cells in their body don't react to insulin in an efficient, good way. They're slow responders to insulin, and they don't respond well. So people thought, well, maybe if we use medications for diabetes, it might have an effect on the course of Parkinson's disease. And there are a couple of these. Pioglitazone is a medicine used for diabetes that also is a potent anti-inflammatory medication. And we think that inflammation plays a role in cell loss in Parkinson's disease. And there was, unfortunately, a trial that was just completed that did not show benefit. But there is another medication, exenatide. I think I'm pronouncing that correctly. I may be mispronouncing it, but it is a potent antioxidant. So it is, there have been some small trials, open trials with this medication that seem to show benefit in people with Parkinson's disease. And there are going to be trials coming forward that will test this medication. And the interesting thing is, what does exercise do to insulin resistance? It improves it. So perhaps some of the benefits of exercise may not be through what the effects are on the brain, but the effects on insulin resistance. So I think that that's a real exciting field. One last thing is nilotinib, because last year when I was here, there was a lot of discussion because there had been this very small open trial, that means no placebo, no randomization, that seemed very, very promising in 12 patients. 10 out of 12 got amazing results. So now we're into two trials. One is at Georgetown and one's being sponsored by the Parkinson Study Group that are double-blind, placebo-controlled. They're phase 2. They're looking at safety and tolerability of nilotinib, which is actually another repurposed medication. It's a medication that's been used for a long time for a certain type of leukemia. But it seems that at small doses, it helps brain cells get rid of some of these bad proteins. So that's, I think, really exciting news too. So I think there's a lot of different interventions that are being tested right now that really are exciting to me and should be exciting to all of you folks as well. So,
thanks, Dr. Ross. With that, I'd like to thank the panel for their time and expertise, provided a ton of good information. And with that, the only announcement I have left is September 19th, Sunday, is the 2018 Hawaii Parkinson Walk. So we would love to see everybody out there. We'll have another big resource fair like we did here. Love for everybody to come out, help us raise some money for the association to help support you with all the programs that we do. With that, thank you so much for coming. Everybody go get some lunch, get some food, and be safe going home. Aloha.